And our first talk is Psoas muscle area as a prognostic factor for survival in patients undergoing Evar conversion from Gainesville, Florida.
Hi, good afternoon. Thank you for the opportunity to present. I'm one of the first-year fellows in the University of Florida. I have no relevant disclosures. Endovascular AAA repair, EVAR, accounts for about 80% of all AAA repairs in the U.S. EVAR reintervention is common. Up to 30% of patients end up needing an EVAR reintervention. Now, EVAR conversion, the final reintervention, is increasingly being reported, with a morbidity of up to 50% and mortality of up to 10%. This is associated with increased technical complexity compared to primary native open aortic repair. And what we've seen is that as the total number of endografts placed are increasing, so too are conversions. This is data from our institution over the last 20 years, showing the increase in EVAR conversions over the years. What we found is that for our institution, almost 50% of open AAA repairs last year were EVAR conversions. So why are we having to explant these EVAR devices? Well, we just published this in JVS earlier this month, and what we find is that the indications for conversion are increasingly for a mycotic or infected endograft. That's up to roughly almost 20%. And then the lion's share of these EVAR conversions are for type 1 and 3 endoleaks. That's relatively stable over the years that we found at our institution. And then for rupture, too, that's roughly 15%. So are there predictors of outcomes for survival for these patients? What we found is that non-elective admission, renal mesenteric revascularization, and comorbidities actually were associated with decreased one-year survival. Age greater than 80, kind of surprisingly, and then any supramesenteric cross-clamp without any additional reconstruction was not associated with any increased mortality. So interestingly for EVAR conversions, these patients, they were initially, when they had their EVAR device placed, they were likely deemed too high risk for open aortic repair. And now you take these patients that are definitely older, may have more comorbidities, and then you convert them, which is a greater physiologic hit than a primary EVAR. So frailty is important. So we're seeing that's increasingly being recognized as an important predictor of both short and long-term outcomes of large cavitary operations, such as Whipple's, esophagectomies, and AAA repair. So other than just age and comorbidities, how can we assess frailty? There are current measures of frailty, a lot of different scoring and ways to calculate this, but they can be cumbersome, they can take time. And some just focus on comorbidities, which may over or underestimate their biologic or physiologic frailty. So it'd be nice to have a kind of a helpful point of care frailty assessment to use in conjunction with others. And what, good characteristics for these would be something that's rapidly able to assess, resource sparing, and then extracted from existing CTA information. So PMA, psoas muscle area, it's been shown to be a predictor of outcomes in several large cavitary operations and general surgery. Now, PMA is a marker of frailty calculated from cross-sectional imaging. And the question is, well, does PMA correlate as a marker of frailty for EVAR conversion? So the purpose was to describe and analyze our experience with EVAR conversion and compare EVAR conversion to those with greater psoas muscle area with those with less PMA to see if PMA is an accurate predictor of outcomes. This is a single-center retrospective study. All patients underwent a preoperative CTA, and this is both partial and total EVAR explants for both elective, symptomatic, and rupture cases. We did, however, exclude any of the infected mycotic cases. This is over 2002 to 19. CTAs were evaluated by a single reviewer, blinded to the patients, using Citrix web data. The psoas muscle area was evaluated at the mid-body of the L3 vertebrae, which is the best approximation of whole body muscle mass. The PMA essentially is calculated with bilateral the right and left psoas muscle area and just averaged out. The lowest tertile was used as a cutoff. Essentially, these patients had low PMA, and then the upper two tertiles were used as normal PMA, and this was taken from prior general surgery PMA papers as kind of an accurate cutoff. This is a representative slice, axial, sagittal, and coronal, just looking at the L3 vertebrae of a patient needing to undergo EVAR conversion. And then this using essentially the Citrix Visage software, able to calculate the right and the left and average it out. This is a representative sample of one of the cases we did last month with Dr. Upchurch, one of the Evar conversions. And then this is a total endograft explant and the nice aortobiliac reconstruction with the left renal artery bypass. And the patient did well. So our primary endpoint is evaluating if PMA correlates with one-year mortality, and secondary endpoints are complications, readmission, reintervention, all-cause mortality, and overall survival. Did a univariate analysis looking at intergroup comparisons, and then Kaplan-Meier models to estimate survival. What we found is that for those with low PMA, they typically were older, unsurprisingly, more often female, and had a lower BMI. We also found they had a little bit lower rates of CHF, but otherwise preoperative characteristics were pretty comparable to those with normal PMA. Interestingly, time to presentation, so time to conversion, the median months is 4 years for those with low PMA and normal PMA. Both sets of groups had time to first EVAR reintervention and total reinterventions were equivalent. Rupture presentation, elective presentation were equivalent. But what we did find, which is interesting, is that the AAA diameter at conversion was greater in those with low PMA at 8.3 versus 7.5 centimeters. Also, AAA diameter increase post-EVAR was greater for those with low PMA at 2.3 centimeters versus 1 centimeter. As far as operative details, supramesenteric cross-clamp, visceral ischemia time, procedure time, tube graft repair, and then whether or not they needed a visceral renal bypass, they were equivalent for both groups, and the low PMA just happened to have about 3 minutes shorter cross-clamp time. So as far as results, the inpatient mortality was drastically increased for those with low PMA at 16% versus 5%. The number of complications was also increased for those with low PMA, especially those being respiratory complications like pneumonia, needing to be discharged on with a trach. Interestingly, renal failure was increased with those with low PMA, but not only that, we saw that discharge on dialysis was 18% overall for those with low PMA versus 4%. So essentially, these patients that go into renal failure with low PMA were more likely going to be discharged on IHD. The length of stay was just a day longer as well. When we broke this down for elective outcomes as well, we saw similar trends. In the inpatient mortality, it's not powered to show statistical significance, but it was 9% versus only 2% for these elective cases. So then looking at survival after EVAR conversion, we found those patients with low PMA at 1 year had about a 70% survival versus 80% for the normal, and then about 40% at 5 years versus 70% for those with normal PMA. So definitely drastically different. So in conclusion, EVAR conversions are fraught with high perioperative morbidity and mortality. For patients with low PMA, higher complications, increased perioperative mortality, and decreased long-term survival may be expected. So as time to conversion and endovascular remediation were equivalent, but sac growth and overall size were increased in those with low PMA, there may be a physiologic link between aneurysm expansion and frailty. PMA may be a predictor of who does worse in the short and long term with EVAR conversion and a helpful counseling tool. Thank you very much.
This paper is open for discussion. As you come up to the microphone, please introduce yourself. Dr. Rajani.
Hey, Ravi Rajani, Emory. Great talk, as we've obviously come to expect from your institution. Two things. One, we generally don't wear suit coats at this meeting, although
I didn't wear a tie, though.
Many of us did it our first time, so I blame your mentors personally. I think it's important to talk about the little bit of selection bias you have. You chose patients who underwent conversion. I assume over the 17-year period, there were patients who had indications for conversion, but the eyeball test told you they wouldn't survive it, and they were too frail. And so is there any way to capture those patients? Because you've already kind of selected patients out that hopefully have a reasonable size Psoas area. Great talk.
Oh, thank you. Yeah, I think that's a really good point, and I think a lot of this when we have kind of our morning meetings, and I think at UF we're a lot more pushing the open envelope rather than further endovascular remediation. That's definitely our bias where we start with. So I'm not sure to really kind of push and kind of delineate those patients that are just too frail. Having said that, we do operate on a lot of patients that I think other institutions would say you're crazy to be operating on, and some of them do poorly, but some do well.
Yeah, so I had a quick question. Great presentation. Did you look at any other measures of frailty that are also relatively easily calculated through some simple clinical factors and compare that to that? Or there are many of those frailty calculators that use psoas muscle area as one of the formulas in it, right?
Exactly, and that'll kind of be for our, our paper when we submit it. We'll kind of go through all that and essentially try to see, well, where does PMA fit with like the RAI score, and kind of retrospectively compare those with an RAIC score.
Microphone to the left.
Hey, Sagar Gandhi, Greenville, South Carolina. Great talk, by the way. I think PMA, sarcopenia is something that we don't look at often. One thing I was going to ask about along the lines of bias and other frailty scores, did you look at people who had sarcopenia or low PMAs at the outset of their EVAR and see if you kind of had that bias where these patients were already kind of subselected to have poorer outcomes because they were sarcopenic from the get-go, or ones that may have, because of their procedure, just as they aged, they became more sarcopenic through time?
No, that would be really interesting. The problem is most of these cases were, from around Florida or Georgia, Atlanta, that get transferred in. So we don't have a lot of their CTs when they had their index EVAR. We just kind of have years later, this is what we get when they show up urgently to our institution. I think that's, definitely would have merit. I would say probably, less than 10% of these cases were EVARs that we did at UF. Most are transfers in, so it's kind of hard to tease that out.
Great, thank you.
Thank you very much.
Thank you.